Good evening, one and all. I'm Dr. Pradeep, and welcome to the monthly webinar by AHRER. We are the Association for Harm Reduction. And in this monthly webinar, the topic will be based on a wellness clinic, a direction in preventive and promotive health with a special focus in tobacco cessation. So joining with us would be Dr. Aruna Badam, and just a brief introduction about her. She did her MBBS in Rangaraya Medical College, Kakinada, and her specialty MD in chest and TB in Andhra Medical College, Visakhapatnam, Andhra Pradesh. She's worked in both private and corporate sectors as a consultant pulmonologist. Uh, Due to her interest in teaching, she has joined medical college and she has about more than 10 years of teaching experience. At present, she is working as an associate professor at the ESIC Medical College, Hyderabad. She has also completed an advanced course in medical education from JNMC, Belgavi Nodal Center. And recently, she has developed an enormous interest in research. And out of this interest, she has published about 15 papers, and she's also authored one chapter in sleep. That is one of my favorite topics, being a psychiatrist. Some of her special interests are airway diseases, tobacco cessation, interactive and innovative teaching methods. And her recent study was a participant of study on salbutamol in asthma, SABINA, clinical trial phase 3 and phase 4, and biologics in asthma, clinical registry on TOPD. One of her achievements, her most outstanding achievements would be Madam has won the Best Doctor Award for 2019 by Sparrows International for training health volunteers as COVID primary caregivers. She is a member of the IMA. She is the member of the Malaysian Association of Bronchology and Interventional Pulmonology. She's also the member of Respiratory Research Network in India, Lifeline League, and also AHRER. She is a member of the COVID committee, mucormycosis committee, and the medical education committee. Some of her hobbies include book reading and aerobics. I welcome you, ma'am, Dr. Aruna Badam. It's a pleasure having you here. Now the stage is yours. Please give us your topic, a talk on your topic.
Thank you very much, Dr. Pradeep. It's indeed a great privilege and an opportunity to be a speaker on AHRER. I've been a member since quite a few months. I have been a participant in all the guest lectures. So with the second wave, we have become a little busy with COVID and mucor. So I was little, that kept me busy. And I'm very happy to be back on here and as a speaker. So I would like to share what I'm doing for tobacco cessation. So it's all related to my work, which I'm doing. And how we can, as an association, go forward in tobacco cessation. So I just have a small presentation I would like to share. My screen is visible, I think.
Yes. Yes, ma'am, it is visible. Yes.
So it is about the wellness clinic versus a tobacco cessation clinic. The habit of smoking, it's a very complex medical and social issue. We have 300 million users of tobacco, out of which 60% are using smokeless tobacco. There are 4,000 deaths occurring annually only due to smoking. So what is the role of a physician here? It is not only limited as an expert in healthcare, but we have a role to, as a protector of public health and also a promoter of wellness as a normal citizen. Now, this smoking is, as we said, it is a very complex disease. It is a chronic relapsing disorder. My slides are not completely visible because of our pics.
No, ma'am, it is completely visible. It comes in a full screen.
Okay. So smoking is a chronic relapsing disorder. It is associated with conditioned behaviors. So what are these conditions? The few conditions are, if somebody is irritated, their mood is not right, they want to have a smoke. Or if they're bored, they're sad, if they are excited, or after a meal. These are a few conditions which provoke the individual to start off the smoking habit. Then the nicotine is the particle which causes this dependency. So, and these nicotine particles, they are designed in such a way that they directly reach the alveoli. Being highly lipid soluble, they enter into the blood-brain barrier within 20 seconds of inhalation. And from there, the psychoactive effects of nicotine will start. This nicotine gets metabolized in the liver by oxidation to cotinine and hydroxycotinine by the enzyme CYP2A6 and CYP450. The addiction for this tobacco is related to some candidate genes and also the chromosome 15. And who are susceptible to addiction is also about metabolization. Slow metabolizers, they tend to have high levels of nicotine for prolonged time. So even the metabolism is an issue. So when we come for tobacco cessation, coming to that point, there are some conditions like, now if a person approaches to us and they're ready to quit smoking, so there is a 5-way approach. And this 5-way approach is supposed to be done at the primary care level by a healthcare worker. So how many of healthcare workers are really trained? It hardly takes 5 to 10 minutes. Yes, that is good. But how many of healthcare workers are trained in this approach? So you just have to ask about the smoking habit. You advise them to stop smoking. You assess the nicotine dependency. You assist in arranging a physician referral for treatment and arrange for follow-up. So these are few things where every health worker need to be trained. When a person is motivated and he is assessed, there is a 5R approach to keep the person motivated. That is, you have to discuss with the person how relevant quitting tobacco is, what are the risks associated with smoking, and what are the rewards of quitting, what are the roadblocks. This discussion aims at planning. So this is the second level for a person who is motivated to quit. So then you repeat this circle of assessment again when at any point of time this cycle fails. We have for nicotine dependency, this is for the physician to initiate the treatment. We have a standard questionnaire. So it is called Fragerstorm questionnaire, which was originally developed by Carl Olof Fragerstorm as a tolerance test. And it is a 6-item questionnaire which assesses on the quantity of the cigarette smoke, the compulsion, and the dependence. So it is also, this is modified by Todd and Hitherton in 1991. And from then we have it in use. But so there are situational points which range from 0, 1, 2, 3. Depending upon the situation, these points are allotted. For cigarette smoking, if the score is more than 8, and for smokeless tobacco, if it is more than 5, it indicates high level of dependence. For example, in a situation like if a person has the urge to smoke in the first 1 hour after getting up, then in that 1 hour, if the person urges to smoke within first 5 minutes, 3 points are awarded. And at the end of 1 hour means 1 point is awarded. Suppose the person is urging to smoke when in public places. If it is a positive response, 1 point is awarded. If negative person, 0 points are awarded. When you add up and you are getting anything more than 8, then it indicates high level of nicotine dependency. And these are the persons, moderate to high level of dependency persons, which require a pharmacological therapy. Only counseling will not be sufficient for these persons. They need a combination therapy of pharmacology and also counseling. So, one question of interest to me and which I am going to discuss in detail is, do you smoke or chew if you are so ill that you are in bed most of the day? So, how relevant is this question today? I will explain in the following slides with a few clinical scenarios which I have come across. Now, for the treatment aspect, I have nicotine gums I've been using. Depending upon their dependency, I start off with 2 mg or 4 mg, or nicotine patches, which are of 7 mg, 14 mg, and 21 mg. This treatment will last up to 4 to 6 weeks. One thing I would like to share is tobacco and the smokeless tobacco is available in every pawn shop. It is also available in households, because in Telangana there are it is one of a gift to the ladies, where they sit in the houses and make BDs, and they earn their monthly income by preparing BDs. So tobacco products are very easily available, but treatment for tobacco, it is very difficult. Not all pharmacies contain these products, and no government or any institute will give them for free. And it is expensive for the patient. This is one hurdle, this is one roadblock for the tobacco cessation management that I have been experiencing. Then, I have realized that we cannot, as a clinician, we cannot, in isolation, we cannot treat the patient. We need a multi-specialty approach, and especially a three-pronged approach. So one is the clinician or a primary physician who is dealing with the issue. The other one is the psychiatrist, and the third one is the dentist. So the psychiatric evaluation is important to aid in the dependence assessment, to control the withdrawal syndromes, and to treat the depression which is underlying or which becomes exacerbated after we are treating for nicotine replacement, or other associated or undiagnosed psychiatric illnesses we have to evaluate, because most of the genes for smoking and psychiatric illness, they are shared. So there is a genetic association. For dental evaluation, if we observe any nicotine staining, but this nicotine staining again, in repeated, when we ask the patient repeatedly also, most of the people deny, and we are not able to establish whether it is true or not that staining is due to tobacco products. And then submucosal fibrosis. After eliminating the causes of connective tissue disorders, the submucosal fibrosis can be attributed to tobacco usage. And leukoplakia and erythroplakia, of course, there are pre-malignant conditions caused mostly by tobacco. So one one scenario I would like to share about submucosal fibrosis is there was once 58-year-old female who came with complaints of shortness of breath, and her symptoms correlated a little bit with the COPD. So when I was asking her whether she was had any exposure to biomass, then there was no history, and also whether there was any smoking history. Then they said 20 years before she was smoking. Okay, so if she was smoking, but she was an occasional smoker, and even she is not also taking any tobacco, other chewing. She's not chewing any tobacco, but still she has submucosal fibrosis and she's symptomatic. So now I have to ask her more about the source of tobacco, whether it's still ongoing. So the caretakers are the son and the daughter-in-law. So the daughter-in-law accompanied her, and she told that now they stopped working, they stopped going to the fields. Before, when they were going to the fields only, they were using this tobacco. Now it has been 20 years that they are not going to the field, and whatever their needs, they are being taken care of by the children. Then on further questioning, I have found out that she has sometimes dental gum pain and headache. So I asked her, what do you do for that? Then she said, I use one toothpaste. So the husband and the wife, they use some toothpaste, so they'll feel better. Their gums feel better and the headache is gone. Then indirectly, I had to assess maybe that is a product which is containing tobacco. So she was further referred to the dentist for further evaluation. Now the challenges, coming to the challenges that I face while delivering my care is the health-seeking behavior. So the health-seeking behavior, again, another example I will give. When a patient comes to us, they'll tell their problems, we diagnose, and we ask them to go for investigations, further investigations. When they're leaving, the attender of that patient comes inside. So then the attender will speak in the absence of the patient. Doctor, please help. This person is smoking heavily, or this person is having or tobacco dependence. So kindly help. So this is where we have to, this situation has to be taken care of. But when we are busy disposing of patients, I don't like this word, but we use this word very frequently. We use this word that we have to dispose the OP. So when we have to dispose the OP, how much of time we cater for this health-seeking behavior? Because this is the first step, and this is a very important step because there is a motivational factor here. The caregiver is motivated. And when there is support of the caregiver, there is so much that we can do for this patient. So we need to think about how to help in this first stage. Then second comes harm reduction. WHO, it has described smoking as smoker. Any person who has smoked 100 cigarettes as a smoker, and an ex-smoker is somebody who has stopped smoking for 28 days. And what is this harm reduction? No, I define harm reduction as somebody who is motivated to quit. So when they're motivated to quit smoking, slowly, because of their nicotine dependency and because that they are not able to get pharmacological help or professional help for nicotine dependency reduction, they slowly shift to smokeless tobacco. And for them, the definition of harm reduction is shifting from one tobacco product to another tobacco product and keeping that high, the same level of nicotine. Then when it's come to disease control, this is again a very complicated issue, because when the disease is there, it is mostly multi-system involvement. So all the systems have to be taken care of along with the tobacco cessation products. If any one comorbidities are not addressed properly, the patient here will not be properly motivated to quit smoking. When it comes to relapse, these are the patients who are again highly motivated individuals. They're coming back to us. So this is again another challenge to put them back on the quitting scale. Then the concept of rehabilitation. The concept of rehabilitation, so we have the habit of seeing the rehabilitation centers as something which is a sin or a very not so fancy affair. There is a need to make this rehabilitation as common as we are paying fines in traffic violations. How it is a common affair, the rehab should become such a common affair to reduce the problem of dependency. Then loss for follow-up. This is always a bigger problem, because once the patient who has initiated for cessation is lost into the mainstream, there is more harm not only to the individual, but because smoking is a social problem, we will add more individuals into his circle. New persons might be initiated, or the older ones might be motivated more to increase their habit. Earlier we had two different clinics, like tobacco cessation clinic. For 5 years I was running the clinic without much success. And there are, for my specialty, there are some specialty clinics like asthma clinic, COPD clinic, lung cancer clinic. For COPD clinic, what we used to do is we used to talk about the inhalation devices, then device selection, oxygen therapy. Mostly our COPD patients will have respiratory failure. So invasive ventilation and rehabilitation and vaccination we shared with advice of my psychiatric colleague, because we are in our hospital, we have the three-pronged approach of dentist and psychiatrist. So the psychiatrist said, madam, if somebody is not having any disease and we have to talk to them about de-addiction, then it is not very easy. But somebody who is already diseased, having COPD, and they know how much dreaded is this disease, it is easy to talk to them about cessation. So we thought, why not combine these two clinics as a COPD wellness clinic? And we have initiated a clinic called Inspire, which has the components of all of the COPD clinic, as well as the smoking cessation, which is incorporated into COPD wellness clinic. And this wellness clinic not only caters to the patients, but also to the caregivers and common people. And here, not only doctors, but also non-medical people can come and talk and assist to the patients and give advice to the patients. So this is something like a friendly atmosphere and a maybe patients can form groups and discuss about their problems of their initiation or their cessation. So we can talk to them about the indoor air pollutions, the second-hand smoke, the outdoor air pollution, and air quality index. Now, coming to the assessment of COPD, we have quantifications like the lung function test, the ABGs, and the COPD assessment test. But when it comes to smoking, how can we quantify smoking? Is there any one thing that says yes, because you are smoking, this is this much you are smoking, and this is because of this you have developed this problem? Is there anything like that? We have discussed the Fragerstorm questionnaire, and this is one study or systematic literature review, which says that these questionnaires, they have some inherited shortcomings that are limited by psychometric properties. So we need another scale to assess the psychometric issues. And we have one biomarker, that is cotinine. The normal levels are 10 to 25 nanograms in saliva and 50 to 200 nanograms in urine. And there is AMI and all who have studied the relationship between cotinine and the nicotine dependency. So the scales which say there is a moderate correlation with salivary cotinine, and when there is a combined for smoking and smokeless tobacco in combined users, then the association is a little better. But can cotinine measure true smokers and true non-smokers? That is again a limitation. So coming back to the question, like, do you smoke or chew if you are so ill that you are in bed most of the day, from the nicotine dependency questionnaire? Our COPD patients, as I have discussed, they have hypoxic. So they get admitted when they have an exacerbation. Their oxygen levels, they fall suddenly, and they come for an admission, and oxygen is delivered either through nasal prongs or face mask or breather bag or positive pressure ventilation or a mechanical ventilation. Why I am emphasizing on these devices is, here, if the patient wants to smoke, the patient cannot smoke because the oxygen is being delivered, and immediately there will be a fatal fire accident. So when my patients were being administered oxygen by nasal prongs, the next day I go for rounds, then still they are not getting better. When I find out what is the reason, then I come to know from the nurses that once we all leave, the patient goes to the bathroom or goes out to the corridor to smoke. So a physician's advice or a hospital environment is not enough to curb smoking. Now, the place where I'm working now is totally smoke-free, because we have fire alarms installed at every place. So an institutional commitment at that level is very much important in delivering care to the patients. So these patients, what I found out was, they have shifted to smokeless tobacco in order to continue smoking in spite of receiving oxygen. In spite of so much of illness lying on the bed, they are still substituting with smokeless tobacco. Then a further deterioration when we go for mechanical ventilation, where the CPAP or a BiPAP is advised, Here there is a mask which is tightly strapped to the face, and we have to give more air is blown into the mouth. Here the patient cannot chew tobacco. So here that also is cut off to the patient. So there is these conditions. These are the established conditions where you refuse the treatment for CPAP. So we have 3 case studies in ICU, which we have found that tobacco withdrawal also is one of the reasons for CPAP refusal. What happens when the patient refuses non-invasive ventilation? The patient has to be put on to invasive ventilation. And this is the time when we are initiating the patient to mechanical ventilation. We tell the attendants that we are not sure that the patient is going to come out of the ventilation. So this is a life and death matter. And then at this point of time, till now, the patient or the patient attendants denied the habit of smoking. Now, at this point of time, they ask us why this has happened. Just because they have not continued to use the CPAP or BiPAP. So then they tell us, yes, because they are having the substance dependence, we are able to give them tobacco products. And that is why they were not tolerating. So once the patient is unconscious, we started with the nicotine patches, and the patient was better, and they got discharged. So these are certain experiences where we learned that we cannot deny on any questionnaire or statements by the patient about their smoking habits. So coming to the implementation of total ban of tobacco, I'm coming to the end of my presentation. So I like this paper about Purva Salvi, who has researched on Navi Mumbai residents, and she found out what are the reasons for dependency, what factors are there, and also how it can be controlled. So in that study, she says that a person who is above the age of 25 and who is not having the daily habit of using these products, the dependency can be cut down by 60%. So is it possible to increase the age of the availability to 25 of these products? And there should be a dissemination of information of tobacco content and its harmful effects. Then the vicious circle, the association of tobacco with alcohol and other substance abuse. So this has to be broken, because tobacco cessation itself is very complex, and when it is associated with other factors, it becomes even more complex. Now I have an invitation next week to be a guest speaker in a school. So what I thought was, if I can impress, now this time I have chosen to speak about tobacco cessation. So if I can influence school children to pledge against indulgence, to encourage hobbies, because it's very important to catch them young, and to curb initiation in the first level. If all of us can do that as AHRER members, I think we can make a good beginning for tobacco cessation. And so with this, I look forward for any discussion. And again, I thank you all for giving me this wonderful opportunity. Thank you.
Thank you, ma'am. Thank you for the presentation. I should say that all your slides, the entire presentation was so neat all the slides were crisp and clear. The color, format, and the way you presented everything was very interesting. A topic like tobacco cessation, we need to capture the audience's attention. I think your presentation, it did capture everyone's attention, and especially the use of mnemonics was very useful. So now I can remember what the 5 A's are, and all these would be even more effective. And I was actually wondering that, when your students, as an academician, when your students listen to such topics, I'm pretty sure they would, all the students would be understanding and absorbing everything that you wanted to say. Now, when it comes to questions, before that, I wanted to tell you about your initiative for school children. When you said that, capturing them at a very young age, enlightening them about tobacco and all these products, I think that is an excellent initiation. Myself being a psychiatrist, I myself have made a few presentations in some of these schools, 10th and 11th standard students. Those classes were very rewarding because, for an academician, the rewards would be the questions which people ask at the end of the program. And at the end of every such program, I was having the pleasure of answering at least 10 to 15 questions surrounded by children, just because they had this absorbing capacity. So they were acknowledging, and I'm very sure that your initiation will also end up with such excellent results. Now, I just want to make a few questions, just one or two questions. In your talk, you had spoke about rehabilitation centers. Do you have any such experience with rehabilitation centers which are exclusively present for tobacco users or tobacco chewers or smokers? Are there any such places here in India? Do you have any experience with that?
We have a helpline by Government of India. So I also registered myself to see how they are functioning. So I used to receive a regular call from the ministry to see how I am progressing with the cessation. But having comprehensive programs will be limited to, I think, individual interest and clinics which are run by highly motivated physicians. I think we need to, main reason is the lack of training and experienced personnel to deliver such services. I think that is the biggest limitation.
True. Very true. I've heard of such rehabilitation centers abroad, and there are also a lot of group therapy sessions where people unite. For alcohol, there is Alcoholic Anonymous. For tobacco users, there is something called Nicotine Anonymous. People who join such group therapy sessions. Over here in India, I don't think it is so well versed. I had the pleasure of going to a rehabilitation center in Thailand a few years ago. And one such rehabilitation center was exclusively for tobacco users. So that brings on to my next question. Based on the visit to that rehabilitation center, I was able to have to view an interactive session between a tobacco user and the treating psychiatrist. So when the psychiatrist was having an interaction, they were allowed to smoke. Their concept was reducing the levels of cigarettes one by one. So in that session, I was able to see the patient smoking a cigarette and the psychiatrist sharing the same cigarette. So that brings me on to the next question. What do you think about smoking, the habit of smoking and chewing tobacco among doctors, our fraternity, among healthcare workers in general?
See, for smoking doesn't differentiate. It is the person, and for any person, the harm is the same. And as I said in the beginning of my talk, that it is a very complex disease with medical and social aspects. as well. And also there is something called conditioned behavior. So this conditioned behavior, it starts early. When it is starting early, when the habit starts early, it is even more dangerous. That's why if we delay that conditions, then there is benefit. But if we succumb to the conditions, just like that, if we start off for the conditions, then and we continue to yield to that conditioned behavior, then it becomes very difficult. It doesn't differentiate between whether you are a doctor, whether you are knowledgeable, or you are illiterate, but it is a person yielding to the conditions. That is very important. So
I
it
totally
is
understand.
have a network of you should be surrounded by good friends and relatives who can uh, like support you during those conditioned situations.
Yeah, I get it. One other way of looking at it, one of my professors always used to say that doctors are the worst patients. Generally doctors tend to have a very poor health record, both physically and mentally. So, what is your experience on making doctors to quit tobacco or use tobacco harm reduction inside this healthcare work of fraternity?
Yeah, we should have like hobbies where we can share. We should indulge in those hobbies together, and we should work out developing those hobbies. And we should be rewarded for such things. We should have more frequent. See, we have CMAs, yes, but we should also have some occasions to show off our talents, where we will be forced to think to develop those habits.
Right. Thank you, ma'am, for that. In one of your slides, during the end of the presentation, there was a slide on total ban, and where the author suggests making tobacco available for about 25 and not above 60 years of age. What is your view on this? Because when it comes to ban, already there is a ban on not selling tobacco products to people below 18, but it is still available in the market, and youngsters do get hold of it, and it acts like a gateway drug. The person who starts smoking eventually starts entering into alcohol and so on, so all the other substances. Now, don't you think that if there is a situation where we make tobacco available for uh, yeah, widely available for people about 25, don't you think it again keeps the same risk of exposing the people below that age also?
Actually, when I was preparing for this session, I came across one paper which was discussing about one country which introduced total ban and what are the effects after that ban. But unfortunately, I could not read that article completely. What I agree is like the precious time, the school and the college period, this has to be properly cultured with sports.
Yeah.
Physical education is very, very important, and it is very important to make it compulsory also. And then I think naturally, when people don't think about falling into those habits, so culturing the environment is very, very important. So I think.
That's great. Okay, the last question. This question will be our favorite question. I think all the members of the HRER would be favoring this one topic called electronic cigarettes vaping. What do you think about this ban on electronic cigarettes? What is your experience on using this as a treatment modality? Have you used it, or have you suggested it to any of your patients? Have they quit it?
Yes, in one of my slides, I was talking about harm reduction. And harm reduction is defined by the patient himself, whether to cut down on the cigarettes or to shift to low nicotine containing products or to other products which are lessening the habit. So it is defined by the patient and it has to be encouraged. to help you.
Thank you, ma'am. Thank you for your valuable insights. I think for the next presentation, we should have you as the speaker, and maybe we can discuss about this one paper which you missed to read. Maybe we'll dig deeper into that paper. And thank you very much for such a presentation. It has been a pleasure. I hope everyone had a good session of updating your information and your fund of knowledge. Thank you for joining us, ma'am. Thank you very much for this session. Thank you.